We will now proceed with the second speaker for today, which is Dr. Gabriela Fernandes from Porto. She's an oncologist by training and will tell us a little bit more about biomarker testing in non-small cell lung cancer. Thank you very much, Dr. Fernandes. Please go ahead.
Hello, dear colleagues. I'm very pleased to be part of this session, and I want to thank Thermo Fisher for the invitation. My talk will be about the present lung cancer diagnostic test needs, and I will focus the importance of the genomic diagnostic in the context of the current lung cancer treatment and the role of next generation sequencing. Also, I will focus the importance of having a comprehensive understanding of the tumor biology and the resistance mechanisms, and the added value of liquid biopsies in the molecular diagnostic algorithm. So, last few years, we assisted to shift from short-term palliation to long-term survival with good quality of life in lung cancer treatment. First, with the introduction of target therapies to driver mutations, then with checkpoint inhibitors, and recently with combination therapies. But the most important turning point was the introduction of target treatments. We know that patients with target therapies live longer than those patients with a target but no treatment, and those patients without an oncogenic driver. So lung cancer genotyping is a new standard of care. And with this table, I want to give some examples of the efficacy of target therapies. Green are already approved drugs for first-line treatment of patients with EGFR, ALK, BRAF, V600E, ROS1, and at gray, drugs that are under approval process. But generally, we can see that response rates are very, very high, above 60, and can attain 80% or more. And patients have overall survivors higher than 3, 4, 5 years. As an example, we have ALK patients that are treated with sequence of TKIs that can live longer. So, all guidelines advise to test all patients with advanced adenocarcinoma or possible adenocarcinoma, and some other patients with squamous histology that have no tobacco exposure or are light smokers or are of younger ages. And what we need to test? We need to use a target genotyping panel that includes the alterations that we can treat. And these alterations can account for around 30% of patients with adenocarcinoma. And if we are in the standard care setting, we need to test EGFR, ALK, ROS1, BRAF. But if we have access to clinical trials or off-label treatments or access programs, we should include also RET, MET, exon 14 skipping mutation, NTRK, R2, and even KRAS. So we also, in the near future, will need to test early stage patients. Data presented this year from the ADARA study where patients that with EGFR mutations that were treated surgically were submitted to adjuvant osimertinib and compared to placebo, and we can see that disease-free survival is much, much higher than those that were treated only with placebo. Based on all this data, we need to have a very good strategy for our molecular diagnosis. And we still know that genotyping is still a problem. Some patients start treatment before having genotyping results available. In our own experience, when we use the multi-step sequential approach, after EGFR testing, about 20% of the patients have no more tissue to proceed with ALK testing. So based on this and also on local cost efficacy analysis, we no longer do this sequential approach. We adopted target gene DNA panels, and we can see that we have a dramatic reduction in the percentage of patients unclassified or non-mutated, as we can see here in blue. And if now, when we started to use a combined DNA and RNA target gene panel, only around 33 to 40% of the patients remain unclassified. And consequently, we increased the patients that are treated with first-line target therapies. It is also advised, and our workflow is similar to this one, to advise to use a reflex test where the pathology, after confirming that it is a lung adenocarcinoma, sends a sample directly to NGS testing and proceeds with PD-L1 expression determination. And with a reflex strategy, we can reduce the time between the biopsy and the treatment decision at the tumor board for around 14 days. Also very important to highlight is that we need to have the genomic test result before start immunotherapy. Not only because the higher efficacy, as I've already mentioned, but also due to the lack of efficacy of immunotherapy in most molecular subtypes other than KRAS. Also, there is now a concern of a higher risk of severe lung toxicity with TKIs after exposure to immunotherapy, as it occurred in patients with EGFR mutations treated with osimertinib that were previously exposed to pembrolizumab. So, the very first step for treatment decision must be to match patients with targetable genomic alterations to targetable treatments. And if there is no targetable genomic alteration to treat, we proceed to other alternatives as immunotherapy, combinations, or even chemotherapy. Another very important need is to understand disease evolution and resistance, and to understand why patients with similar molecular characteristics have different evolution and different outcomes. A good example of that is can be explained by the coexistence of other alterations. One example is this one, the presence of the TP53 mutation associated with EGFR and ALK and ROS1 alterations is associated with poorer survival in patients treated with target therapies, as we can see here in the green line of these Kaplan-Meier survival curves. Also, a very interesting point is the influence of these co-alterations in the response pattern to immunotherapy. This mutation, STK11LKB1, is demonstrated to be a genomic factor for primary resistance to PD-1 inhibitors in patients with the KRAS mutation in several quarters and also in clinical trials. But one challenge is still to understand the genomic happenings at progression of patients treated with target therapies. And again, EGFR is a very good example. With the frontline use of third-generation TKIs as osimertinib, we can see that resistant mechanisms are very heterogeneous and complex. And to capture all these alterations, we need to have NGS tools. And this takes us to the other point that many patients, when progress, are not fit to do a rebiopsy. So we need more other mechanisms to test for resistance mechanism, and we need less invasive tests. And the liquid biopsy is a good perspective. In lung cancer, the detection of the EGFR 790M resistant mutation is already approved and advised by guidelines. We need to know the test performance and limitations. We know that sensitivity is not perfect, and due to that reason, if we have a negative result, we should confirm it with a tissue biopsy. But on the other hand, there is a good correlation of a positive result with clinical outcomes. So we can use a positive result to guide our treatment. But we can move forward and use ctDNA analysis for the initial genotyping of lung cancer. There are several studies, this is one of ours, to compare the NGS panel in tissue and in ctDNA. And we found that the test is good with a high sensitivity and a very high positive predictive value. But it is also important to prospectively confirm this and to analyze the impact that this kind of tests may have on clinical outcomes. And this is showed in some already published studies. This is one very good and very interesting example. We can see here that the use of ctDNA analysis to genotype lung cancers at diagnosis can increase the number of patients with targetable mutations. In this graphic, there is a very high concordance between tissue and plasma. There are some cases that are only found in tissue due many reasons of sensitive in some cases, but most of all because of non-shedding tumors or a low tumor burden or intrathoracic disease exclusively. But I want to highlight the number of cases that can be found exclusively only in plasma. So there is an added value to use ctDNA to molecularly profile lung cancer. Also in this study, they proved that patients that were selected based on ctDNA results had the expected clinical outcomes, so it can use to guide clinical decisions. Another interesting study that had similar conclusions, but also looked to the turnaround time and compared the turnaround time between tissue and plasma analysis, found that with the plasma analysis, turnaround time was lower, 9 days versus 15 days. So another very interesting point is the use of liquid biopsy and ctDNA analysis to monitor clinical evolution and response to target therapies. This is a very nice example where we can see the clearance of mutations in plasma with clinical corresponding to clinical response, and then the appearance and rising of the T790M resistant mutation that declined with osimertinib, and then at progression the emergence of this new C797S mutation, resistant mutation. Still, this is a very interesting approach, but it needs to be clinically validated. So, finally, as conclusions and take-home message, I would like to say that genomic testing is fundamental to guide our treatment decisions. We need to have results before any initiation, any treatment initiation. Tissue is still the gold standard, but ctDNA analysis proved to be of added value and can be used mainly when tissue is not available or a biopsy is not feasible. Also, and finally, that small hotspot gene panels can be a reasonable option and with a cost and time efficacy relation very positive. And thanks for your attention.
Thank you very much, Dr. Fernandes, for this very interesting talk.